Good evening, my dear colleague.
Recording in progress.
Good evening, my dear colleagues and friends. On behalf of the Indian Academy of Otorhinolaryngology Head Neck Surgery, it's my pleasant duty to welcome you all to this webinar series 5 on contemporary ENT practice. And today's topic is on voice disorders. Today's topic is quite interesting as it's one of the common conditions which we all encounter in our day-to-day practice. I welcome Professor Karen Cost, who is the director of the Voice and Dysphagia Lab at McGill University, Canada. And she is our keynote speaker today. She would be deliberating on office-based procedures in laryngology. We also have Dr. Kumud Kumar Handa, our current president of the Academy and a senior consultant at Medanta Hospital, Gurgaon. Dr. Handa doesn't require any introduction. He's one of the pioneers in voice disorders and phonosurgery. He's one of the first consultants, I should say, who actually started practicing phonosurgery and made it and inspired many of the youngsters to specialize and practice this subspecialty. So he would be moderating a panel discussion and on the topic of voice disorders. So without much ado and wasting much time, I would now invite Dr. Kumud Kumar Handa to start the proceedings, please.
Thank you, Professor Panda. It is very kind of you to introduce all of us. Today, the topic is voice, and it is structured in a way. We will have a very, very interesting talk from Professor Karen Cost from McGill University, Canada. She'll be talking on office-based disorders. Then a short talk on lasers in early cancer larynx. And then a very interesting panel discussion where we have people who are really known names in the country in phonosurgery. And we will be touching on a simple but very, very interesting topic of polyps, nodules, cysts, and sulci. What are the problems? What are the issues? Now you see voice disorders, they form a large group or subgroup of ENT practice. And today it has become a subspecialty by itself. This is a specialty which is, say, technology focused. You need cameras, you need stroboscope, you need laser. So, but this is something which is very much what you visualize is the diagnosis. There is very little abstract in it, like vertigo. Vertigo, a lot of things you have to work on assumption. But here, the lesions are in front of you, the patient is in front of you. You make a diagnosis and you proceed forward. But it is not just a surgeon's work or a clinician's work. We have very, very important persons. Others like voice therapists. Today in our panel, we have Divya Chandrasekhar. She's from Bangalore. Previously, she was in Medanta, Gurgaon. She is a voice therapist. And for professional voice singers, users, we have music coaches, we have music teachers, and a lot of people who are involved in care of professional voice. So voice is something which has become a subspecialty, but we are learning every day. New things are coming and the spectrum is widening. And this subspecialty today also encompasses airway and swallowing. Swallowing has again become a very big field and is a topic by itself. You have head and neck cancer patients, you have neurological patients, and then you have airway, again a very vast field. So all these are brothers and sisters of voice. So without taking much time, I will call on Professor Karen Cost. Karen is one of very credible international phonosurgery persons on circuit internationally. I interacted with her first time when we had the World Phonocon, the APSI meeting in New Delhi 3 years back. And she is a professor of ENT in McGill University, Canada. And her main interest is obviously voice and laryngology. So she will talk on office-based procedures. Again, especially in US, there is a shift from OT to the OPD, trying to do things in a much simpler and faster and probably economical way. So she will tell us how she takes this on, office-based procedures. So over to Professor Carol.
Thank you so much, Dr. Handa, for that kind introduction and for the invitation to speak at the Indian Academy of Otolaryngology Head and Neck Surgery. And I'm just going to share my screen here. Do you see me?
Yes, we can see you.
Okay, very good. So yes, today we're going to talk about from the operating room to the office, this incredible transition which has taken place over the last decades. And I do want to disclose I am a consultant with Pentax Medical. So let's roll back the clock and look at a laryngology operating room list 20 years ago. What were we seeing on this list? Well, we did all of our injections in the operating room under general anesthesia. This was often Teflon. We did our laryngoscopies in the operating room, often without a microscope. There may have been one, but there was often no microscope. And when we saw a polyp, we were taught to take a large forceps, grab the polyp with really not much concern about where we were grabbing it or how deeply we were grabbing it, and just pull it off. And that's the way we did surgery for the larynx. In terms of biopsies, patients were brought to the operating room. Again, general anesthesia. We would do a biopsy of the suspicious lesion, and if we were contemplating surgery later on, the patient then had a second anesthetic a few weeks later to remove, for example, carcinoma in situ. At that time, the standard of care for T1 lesions of the larynx was radiation. So we did a biopsy and all patients got radiation. We weren't really even talking 20, 30 years ago about surgery for these patients. And how did otolaryngologists evaluate the esophagus? Well, again, that meant usually a general anesthetic and a rigid esophagoscopy. So let's fast forward 20 years. What has happened? Well, there have been incredible technological advances. So scopes aren't just scopes. They are high definition scopes. They have working channels. They have suction. And this has just transformed what we do. The other drive to shifting things from the operating room to the office is, apart from safety to the patient and so on, is the fact that operating room resources are extremely sparse these days, and particularly with the pandemic, this is a real concern. So there are many factors which have driven this shift. And if we look at our clinic, and we just did a little impromptu kind of survey, we do an average of 15 to 20 outpatient procedures per week at this time. That's about 600 per year between 3 laryngologists. So this is 600 patients that would have potentially 2 decades or 3 decades ago have undergone general anesthesia for this. It's all done in office under local anesthetic. And for the patient, this means no downtime, which is critical. So it's important to consider that when we talk about laryngology, this is one of the riskiest subspecialties because you can't escape the fact that you're working in the airway all the time, whether it's for a vocal fold injection, a laser, or transnasal esophagoscopy. And so we constantly run the risk of laryngospasm, and we know of some tragedies that have occurred as a result of this, airway edema, hematomas. So these are all concerns that we have to factor in when we decide to do office procedures. So I thought I might run through some of the common office procedures that we are doing at the moment, and I might mention some of the ones that we are working on towards the end. So the first is, of course, injection laryngoplasty. I would say that 95% of our patients undergo this in the outpatient department. It is only rarely done in the operating room when you really can't see where you're going to inject, or you just can't find the anatomical landmarks. Why is this important? Well, we know that patients with paralyzed vocal folds have significantly lower quality of life scores compared to normals. They suffer from physical, emotional, social difficulties. They may not be able to work. Their voice is compromised, but very often their swallowing is compromised. And it's been shown in the thoracics literature very clearly that if you don't intervene in a patient having undergone a thoracics procedure with a vocal fold paralysis and dysphagia and aspiration, their length of stay in the hospital will close to double. So it's very important to treat these patients early. And treatment, of course, has a dramatic effect on quality of life. And of course, the VHI or vocal handicap index as well. It's easy. It can be done the same day in the office, no downtime. So we often will see these patients and inject them immediately unless there's a reason not to do so. So there are several approaches to this. I'm only going to mention the ones that I do most frequently, and that is the cricothyroid approach, just because it's generally quite easy to see and feel the cricothyroid membrane. We inject it we use topical anesthesia, inject intratracheally as well. And this would be an example, an individual with the right vocal fold paralysis, and I think you can see the needle going into the right vocal fold. So you can actually control where the needle goes quite precisely. The other point I want to make about these injections is that, you know, when you read the textbook, there are some tricks that are not really mentioned. One of the tricks is keeping your needle as close to the lower border of the thyroid cartilage as possible in order to be close to your target. The further away you are, the more difficult it is to angle that needle directly where you want it to be. And you can see the vocal fold gradually filling there. Less commonly, I will use a thyrohyoid approach. I find that this approach is most useful in patients where you really can't feel the cricothyroid membrane, or they've had a lot of neck surgery, or if it's a very obese neck, it can be very, very challenging. And so in this case, the thyrohyoid approach can be very useful. The key here is learning how to angle the needle. I generally angle it twice, and it has to be a fairly sharp angle. The needle goes in at the thyroid notch and is directed vertically downwards to exit somewhere around the petiole. And as you direct it downward, you want to just gently direct it to the side where you want to inject. And the reason is that you're traversing quite a lot of soft tissue. And so once you're actually into the larynx, it becomes difficult to direct the needle to one side or the other. So it's best to do that as you are entering the larynx. And there you can see the right vocal fold paralysis. And we're going through the thyrohyoid membrane. It's important as well to direct the needle right at the notch, because the length is the length of the needle. So you want to make sure that it's long enough to reach your target. So here it is being directed into the vocal fold. And I always start with a very small test dose to make sure that I'm happy with the location. So this is entering about the mid-vocal fold, but the actual tip of the needle is in the posterior third. And you can see the vocal fold just gradually filling up there. So, of course, we don't only inject fillers, and the ones that are commonly used, of course, in terms of fillers are calcium hydroxylapatite and hyaluronic acids. I do want to mention, personally, I've stopped using calcium hydroxylapatite, and the reason is the very rare but quite dramatic idiopathic inflammatory reactions that some patients have as a result of this material. If you have this, there's not a lot to do about it. It's also a very unforgiving material. So if you train residents and the residents don't inject exactly where you want that material to be, for sure, it's going to be extremely challenging to correct that. Now, apart from fillers, we use other injections, cidofovir, steroids for various indications. So here we have a young man in his 30s who uses his voice for his work, has had multiple surgeries, probably 3, 4, 5 a year, and has noted with each operation a deterioration in his vocal quality. And he's worried that by the time he's 40 or 45, he really won't have much of a voice at all. And so he was referred to us to see if there was anything else we could do. So we decided that we would try some cidofovir intralaryngeally and see if we could keep him out of the operating room with that, and maybe do an occasional KTP laser if that was necessary. But it proved not to be necessary. We injected him with cidofovir. As you know, there is no standard dose for cidofovir, and there is no standard interval for giving the cidofovir. And so we decided in this gentleman that we would give him an intralaryngeal injection every 3 months for a year and see how that went. He responded very well. You can see he's already got quite a significant anterior web from the multiple preceding procedures. And here we're going through the thyrohyoid membrane again and directing the needle. Now we have to remember this is a mucosal disease. We don't need to go into the thyroarytenoid muscle. We want to be just under the mucosa. And so you'll see very quickly the vocal fold balloon out, which is what you would expect if you're in the right layer. And we've managed to keep him out of the operating room since we saw him initially, and that's probably about 3 years ago now. Now, we used to take patients to the operating room for biopsies, and we know now, again, this is something we do the same day in the office, no general anesthetic, no pre-op clinic. This expedites the diagnosis. Patients walk in. If you've got a suspicious lesion, we do a biopsy, and within 48 hours, we have the answer. And, we do this through the working channel of a laryngoscope, flexible laryngoscope, of course. And what's really interesting is, the biopsy forceps that you put in through there can be manipulated and turned so that you angulate them in the direction that you wish. So here's a very leukoplakia, and here's the forceps. And we direct it in this case so that it's parallel to the, and this really allows you to get a very nice sample of the lesion. And here we've got a more obvious.
Ideally, what I'd like to do is get this, just breathe through your nose, sir. Get this interface right there. Okay.
So here we've angled our forceps so that they are perpendicular to the direction of the vocal fold, and we're aiming at that junction between the lesion and the normal vocal fold. So within 48 hours, we've got an answer. This case up top, this turned out to be a severe dysplastic lesion, and down below was an invasive squamous cell cancer. Now, about 10 years ago, the KTP laser was all the rage. There have been some difficulties with the company and its administration, and there is now a transition towards the blue laser. The wavelengths are roughly similar. These devices can be used in the operating room, but we principally use them in the outpatient department. And they are associated with a reduced risk of photothermal injury, vocal fold damage, and scarring. That doesn't mean that you can't have scarring and damage if the procedure is not well done. But I think with its judicious use, you can certainly avoid a lot of the negative side effects. It has a huge number of applications, and again is done in the clinic under local anesthesia. And of course, I think we're all familiar with the device you see down below, which is the CO2 laser, which is, again, very, very useful. We use it for a lot of T1 lesions of the larynx and so on. However, there are a huge number of precautions involved in using this laser. And I think sometimes we tend to trivialize that. But the risk of fire with these lasers is real. And I think it's extremely important to understand that. And that's one of the huge advantages of using KTP or blue laser in the outpatient department. So this is these are just some examples of a few of the applications. There are many, many, many others. But, a variety of lesions, vocal fold polyp. There is a hemorrhagic polyp on your right. Down below, some ectatic lesions. Very useful for all of these. For papillomas, keeping patients out of the operating room and jumping on them before they get too big. And here's an example where we topicalize a patient who's got papillomas. And she's not been under general anesthesia probably for 5 or 6 years. Here is a lesion that popped up in the posterior commissure. There are several ways of using local anesthesia. Some people like a nebulized lidocaine. We tend to just ask them to sniff through the nose and then do a laryngeal gargle. The KTP laser can be used in a contact or non-contact mode. And that's really a matter of preference. The advantage of a non-contact mode is the fact that you won't have a lot of tissue sticking to your laser. And this is what she looked like about 3 weeks later. And you can see that there's still a very, very tiny lesion left, which we kind of finished off in a subsequent procedure. My general philosophy with these is that if you have something a little bit larger, I think you're better off lasering what you see and then letting it heal, and just advising the patient that a second procedure may be necessary. That way you target the lesion exactly, and you're not overdoing it and inducing undesirable scarring. And this is a case I've only ever seen once in my lifetime, and I thought I would share it with you. This was when pretty early on when I started doing lasers in the office. This is a 69-year-old male who had been aphonic for several months. He had a severely impaired quality of life. He had end-stage COPD, was on chronic oxygen, hypertension, all the comorbidities you can think of, and was on a long list of medications, including Coumadin. And he was completely aphonic, as I said, and when I examined him, this is what I saw.
So
So, you know, this was quite impressive to me. I've never seen this. And I thought that perhaps if I could get through the mucosa and open up these air pockets and these laryngoseals, that we might be able to get some phonation. And so that's what we did.
swallow again if you can.
This, of course, was very risky. This patient was not, would have died on any operating floor. And we explained the risks of the surgery. He was clearly aware of it and accepted the risks. And it was not an easy procedure, but we did open up those laryngoseals, and he did have a voice which made a huge difference to his quality of life. Now, many people are concerned about using lasers, office-based lasers, on the professional voice and won't use them because they're concerned about scarring and so on. That's not been my experience. I've found both the KTP and the blue laser to be extremely useful in the office for vocal professionals. And this is an example. This is a 44-year-old female, otherwise completely healthy, a TV broadcaster, an anchor, basically on TV every day from Monday to Friday with the news. And I had noticed her, watching her on TV, that she had been quite dysphonic, actually. So I wasn't really surprised to see her show up in my office with this dysphonia. She had just accepted a promotion, and this promotion was coming up in a few weeks, and she wanted a quick fix. So, of course, this is the most dangerous kind of request, is a quick fix. Because I don't really think there are many quick fixes in voice. And so the first thing you have to do with these patients is sit down and talk to them and explain that really our goal is for long-term, lasting success. And there's nothing that we can do in the next 5 minutes that's going to fix this problem. So we did a video stroboscopy, so there were some tears and so on. But through that, figured out the problem. So I think we can all appreciate that there's a lesion on the right vocal fold, that there's a recovering hemorrhage on the left vocal fold, along with some very angry looking ectasias. This is not a happy larynx. And so again, I think you really have to talk to these patients and explain that this is going to take some time. And we advised her that she would need a period of relative, but fairly strict relative voice rest, that she would not be appearing on the evening news for a little while. Our first order of business was to allow the larynx to quiet down, and then to address this right vocal fold.
Almost done, breathe.
Really important during these procedures to engage the patient, to explain what you're going to do, and to have them participate. This is what's going to make it easiest for you. The other thing I want to mention, if any of you have used a KT laser before, is you've got a window of opportunity, and I find that window is about 5 minutes. And you have to plan to get it done in 5 minutes or come back on another day. Because after 5 minutes, patients get restless, they start getting agitated, they start coughing, reacting, moving in a chair. So you have to be fairly quick and efficient. Here she is, about 2 weeks after the procedure. And you can see the mucosal wave is intact. The other vocal fold is looking much better. We went back about 3 months later and lasered those ectatic vessels, which were still there, but were much less prominent. And she did go on to complete her career as planned. And I want to finish, I want to talk a little bit about transnasal esophagoscopy. So what a jump from the rigid esophagoscopies we were doing in the operating room. So transnasal esophagoscopy, I think, has really changed my practice in many ways, has allowed me to avoid the long wait lists that we see with our gastroenterology colleagues. I've been asked many times, oh, don't your GI colleagues, aren't they upset that you're doing this? And isn't this competition? And the truth of the matter is that in this country, if you are referred to GI, you will wait a year to 15 months to see them. So they are delighted that we are participating in this and able to reduce or at least help maintain their wait lists and not increase them. And the truth is that many of these patients require a procedure before 15 months. So, if you had a choice, would you like to have this 10 millimeter scope inserted down through your larynx under fentanyl, or would you rather have this 4 millimeter scope with a working channel through your nose with no fentanyl, allowing you to go back to work the same day? And the data, I think the literature is replete with evidence that indicates that T&E is as accurate as a traditional esophagoscopy, or and at least as safe, probably safer. There's only one reported case in the literature of esophageal perforation that I am aware of, and there are certainly several in the literature with a traditional large esophagoscope. The large majority of patients prefer TNE because it's fast, it's done in the outpatient clinic, and the complications really are minor. And if you've done this, you will know that the most common complication is a little bit of epistaxis. Sometimes the nose is often the most difficult area to get through in somebody with a very deviated septum. Some patients have vasovagal attacks, but again, this is transient. I will occasionally, in very anxious patients, suggest an Ativan or some very small dose of a benzodiazepine just to allow them to get through the procedure. And in our practice, this has been a very useful procedure. In close to 100 patients that we did, we found an abnormality in about 40% of them. So it's not rare to find something that may be unexpected. So I thought I would share with you a couple of cases. Here's a 77-year-old male with dysphagia over 4 months, occasional feeling of choking, hypertension, remote smoker. And we went on to do an esophagoscopy. And I'll just bring you to the crux of the matter. As you know, you really want to be looking at the esophagus. There's the junction and the C-line. And you really want to be looking at the esophagus closely on your way out. We didn't see much as we went down, but just as we're coming out, just below the upper esophageal sphincter, we came across this polypoidal lesion, which we biopsied, and this turned out to be an early squamous cell carcinoma of the esophagus, which, because of its early detection, was treated with laser therapy, intraesophageal, and this, of course, saved the patient from a huge amount of surgery and further treatment. This is a male who had undergone a laryngectomy and had progressive dysphagia over a week. He had liver cirrhosis, was a heavy smoker, an alcoholic, but he suddenly couldn't eat. And so we did an esophagoscopy transnasally. You can see his prosthesis there. And the esophagus looks really quite awful. You've got this patchy white membrane basically circumferentially around the esophagus. And this, of course, is a classic fungal esophagitis. And so he was treated and got much better. And I told you I would share with you what we've started doing more recently in the outpatient, and that is subglottic dilatations for subglottic stenosis and cervical tracheal stenosis that we are now doing in the clinic. And we found this to be also quite successful. We've only done 4 or 5, but we'll be coming out with a series of these shortly. So in conclusion, the technological advances that we've experienced, along with a shortage of operating room resources, have driven a shift from the OR to the office. The advantages, of course, of office-based procedures is that we save operating room time. There are huge benefits for the patient in terms of avoiding anesthetics, huge cost savings to the institution as well, scheduling convenience. You're not waiting on some list, and much less downtime for the patients. I'd like to thank you for your attention, and once again, thank Dr. Handa for his kind invitation.
Thank you, Karen. It was a very, very engrossing talk on the practical aspects of office-based procedures, what all we can do. And she has beautifully shown things which can be done. And believe you me, a lot of things can be done. There is no doubt about that. Now, just one question before we end this, because then you may not stay as you have other commitments. there is a question from the audience. Which forceps are you using for your biopsies?
Oh, it's actually an Olympus forceps that fits through the working channel of our scope. We also, it's long enough that we can also use it through our esophagoscope. So we use it for both. Yeah, it's a pretty standard forceps.
So it is one of the accessories which come with the Olympus, these fibroscopes.
It doesn't come with the scope. We actually use different scopes. We use Pentax scopes, but we use the Olympus biopsy forceps. So a lot of these forceps that have been designed to go through working channels, it really depends on your personal preference, but their characteristics are very similar in terms of the way they open and their appearance. So they almost all fit interchangeably between different scopes. So even if you have an Olympus scope and you want to use a different kind of forceps, it will probably fit through the working channel, which tends to be fairly standard in size. And again, the diameter of these forceps are also fairly standard in size.
You can interchange the different companies if you want to use your choice forceps. Thank you,
Yes.
Karen. Thank you very much. And now
Thank you.
Is on sorry. Just 1 minute, please. So you're getting my screen? So this is on use of CO2 laser in early cancer larynx, defining the limits. Now, this is one area again where, say, laryngologists or even oncosurgeons, they have shown, literature has shown that we can handle this group very well with CO2 laser. Now, this is what I always say. If you want to be a laser larynx surgeon, you have to be a good phonosurgeon. You have to understand the layered microstructure of the vocal cord. You have to understand there is an epithelium, there is a subepithelial space, there is lamina propria, and you have to understand how the vocal ligament is made by intermediate layer of lamina and the deep layer of lamina, and then you have the muscle. Because all your cordectomies are based on the principle of cutting these structures, which are layered structures. And these are functional structures. All of you know, if you touch cut the vocal ligament, the voice, it may be say a permanent damage to the voice. You may have to cut in early cancer larynx, but then it is knowing what you are doing. For your laser program to work, you must have a quality laser which is compatible with the scope, correct set of instruments. You have, this is a distending scope. You must have a buoy because laser is a reasonable hemostat, not a very good hemostat. So as you come near the cartilage, sometimes you need the buoy to coagulate those vessels. Now, anesthesia, very important. The anesthetist must understand the laser anesthesia, laser protective tubes, how much of nitrous this to be kept, FiO2 to be to less than 30. Now, our center, we do majority of our work with the jet ventilation. It gives you the full access to the airway with just a catheter in place, and the whole area is yours. Unless patient has a bad lung or you have regions which will bleed, because the drawback of jet is you can't, there is no, say, balloon. It's not endotracheal tube with a protective balloon or a protective cuff. And secondly, with every jet ventilation, there is some excursion of the vocal cords. You have to learn to work with that. Now, before we come to early cancer, these lesions of uncertain pathology, like hyperkeratosis, dyskeratosis, acanthosis, and then dysplasia, mild, moderate, severe. And then next spectrum is carcinoma in situ and microinvasive carcinoma. And these are all termed as lesions of uncertain pathology. These are very well tackled with CO2 lasers. In fact, you do a excision biopsy, or in cordectomy terms, you do a type 1 cordectomy. Now, I'll just show you a small clip of this sort of a lesion, which looks to be a keratotic lesion on the vocal cord, and you do excision biopsy using CO2 laser. You are protecting the tube. This is with the patty, the threaded cottonoid patty, and you see you are working in the subepithelial plane, removing the lesion. And if you carefully see, the vocal ligament is still lateral, and you prevent any damage to the vocal ligament. So you can have different settings. You can work in super pulse mode, you can work in CW mode, intermittent, continuous, and as your skill level improves, you can do with whatever you are comfortable. So this is one lesion. Then this is the second, early cancer larynx, say T1 lesion confined to one cord. But qualifying part is anything you want to resect with laser, you must have a lesion which is very well visualized. Unless you see the lesion well, you cannot resect. You can't resect a blind lesion. So, and it is fair at times to take out a part of the false cord if you want to visualize the lateral part of the lesion. Only drawback being if you are not doing some reconstruction, when you are trying helping the patient develop voice with the false cords, then that function may be slightly compromised. Otherwise, for access, it is perfectly all right. This is the cordectomy, different types of cordectomies, fairly standard. This is the European classification and helps you understand the cancer and its treatment very well. Now, this is a case we did just last week. This is a lesion, again confined to one cord, but going anteriorly. Biopsy proven carcinoma larynx, operated elsewhere. Biopsy was squamous cell carcinoma. Now, you must understand that in cancer larynx, the margin is only 1 or at the most 2 millimeters. Now, this is a Lindholm cord retractor. At times, we use to visualize the lesion. And here we have defined the lateral limit of the lesion. One is visualization, telescopic, microscopic visualization. Other is the feel of the laser cut. This is a practical tip. You feel by cutting of the tissue, whether you are cutting normal tissue or a cancerous tissue. So this helps you a lot. And you use the laser beam. You are using the laser with a scanner in a cutting mode. And you can see here we are doing a type 3 cordectomy, transmuscular cordectomy. And we can go slightly forward just to, so coming deeper, you see we are cutting through normal tissue. There's a good plane of separation. Smoke, your scope should have a smoke evacuator and also another one assistant holding this. And now the important part is anterior margin. We have already done a CT, the cartilage is not involved. And visualization wise, there was a free anterior part of the cord. So this is the normal anterior part of the cord. Now you have started seeing. Here, if you focus anteriorly, you will appreciate that. There was a small bleeder, so we use a movie to seal that. And this is the final resected specimen. Now, sometimes we can reconstruct where the phonatory demand is high. This is a lesion. We did a cordectomy. I will just run fast, and a laser correctomy done. This was the lesion, and on table autologous fat injection. Provided your margins are clear, you can take help of frozen section, and you can have instant voice. However, if you're not sure of disease clearance, you can do it after in a stage manner. And autologous fat is a very good material, though you can use other materials also, but fat can last up till 2 years, though there is a resorption of about 30%. So if you see his post-op picture after some time, disease-free. Now, these are borderline lesions. We have to be careful whether we are going to do laser in these or not. Here you need to do a CT to see the anterior part, if cartilage is involved or not. If cartilage is involved, it becomes T4, no role of laser. Here there is a skipped lesion anteriorly. So you have to be sure with a CT scan or a MRI. The soft tissue delineation is always better with the MRI. So these borderline lesions, you must, the patient selection should be correct. Here there is no role of laser. You see, this is a transglottic lesion going anteriorly, going to the other cord, going in subglottis. There is no role of laser. If your CT shows cartilage invasion, he goes for a laryngectomy. If it is a T3, stage 3 lesion, he goes for CTRT. Similarly here also. Now, I'll show you something else. How the patients, they learn to phonate after laser resection. You see, it's again a T1 lesion. Laser resection done, and post laser excision, he learns to phonate with his false spots. And if the voice demand is not very high, most of them are all right with that. They don't ask for reconstruction. Now, frozen section, preferably yes. The caveat is the margin is only 1 or 2 millimeters, but again, it gives you a confidence that you resected the full tumor and medical legally. So if available in your setup, better to do so. Now, the radiotherapist, there is always an argument radiation is better for early cancer, but not necessarily so. There are so many side effects of radiation, mucositis, you see the drying of mouth, the woody neck, the neck issues. The biggest problem is if your radiation fails, there is a 5% chance it may fail. There is a 5% chance laser may fail. But if you do a salvage surgery, the tissues are already burnt out with radiation, and the complication rate is very high. In fact, the fistula rate for pharyngocuteus fistula is about 50%. Now, laser, again, very good tool for this sort of a lesion. It's a varicose lesion. I'll just fast forward it. You use laser to resect this out and send for excision biopsy. And this was a varicose carcinoma. So cord reconstruction can be both primary or secondary. It is perfectly all right. Till T3 resection, voice is, it's now accepted fact, is equal to what you get with radiation. Radiation causes endarteritis obliterans. After 12 months, the voice quality goes down. With laser, yes, initially the quality may be a bit stepped down, but with good therapy or with cord reconstructions, you may have equal voice. I'm talking till stage 3 resections. Now, again, serial pictures of a laser resection on table. Now, even in T2 glottic cancer, if your exposure is good, cartilage is not involved, and you are visualizing the lesion well, you can do a laser resection, no problem. Now, this we've already said. These are the problems of radiotherapy. So now there is enough literature to support the use of CO2 laser, and it is an option which must be given to the patients. What we will do is, once we have done a biopsy, once you stage the patient, we will give him the option that either you can go for a laser resection, which is a one-day procedure, less cost, chances of you losing your larynx are lower, or you can go for radiation, which is the second option. So it is up to the patient to decide. And this is a landmark paper where it shows that there is a higher number of larynges preserved after laser resection for T1A. So if your laser fails, you still have radiation in store. But if your radiation, you give primary radiation, that fails, then you have to do a laryngectomy. So this is, now there is a lot of work which has come on transoral laser surgery for early cancer, and cost is less with laser. Even in our Indian setup or abroad also, it's a one-day simple surgical procedure lasting 1.5 hours, as compared to radiation, which is six weeks. And this is Professor Steiner. So my take-home message is, this is an option which must always be given to cancers of early CL larynx, but please stage your tumors, assess them well, use a CT, use a MRI, use a telescopic imaging. If you are confident it's not a difficult visualization, you can do your Mallampatti score or other parameters, or doing a preoperative visualization, especially if your laryngoscopy is not difficult. It is worthwhile giving them option. And if you must have a laser system in place, or refer to a colleague who has a laser in place. Thank you. So now I know all of you are waiting for the panel. Any questions on lasers, please put this in the chat box. We will take it after the panel. We will take it, I'll amalgamate the questions which are put forward to the panelists with this. Now, just give me 1 minute to switch over. So I welcome all the esteemed panelists. We have Dr. Gauri Vaidya. She is a laryngologist and a ENT surgeon from Nagpur. We have Dr. Unni Krishnan Menon. He is professor of ENT at Amrita Institute with a keen interest in laryngology. He is also the current secretary of the Indian Association of Phonosurgeons. We have Divya Chandrasekhar. Divya is a voice therapist currently based in Bangalore. She was with us in Medanta a couple of years back, and she is trained from Ramachandra Institute in Chennai. Then we have Dr. Annaga Joshi. She's a professor of ENT in Mumbai, again with a keen interest in laryngology. And last but not leastly, she should have been introduced first, as Dr. Nupur Nerurkar. All of you know her. She's a laryngologist from Mumbai, my very old companion for many years. We will be missing Dr. Jay Kumar. He was in the panel, but his wife has undergone a surgery on Thursday, and she is still not come out of ICU. So he just sent me a message about half an hour. So we will miss him. Now today, we've had a very good talk by Professor Karen on office-based procedures. What we are going to discuss today is something very simple. It is not a very high-flown topic, but something very, very relevant. These 4 conditions, nodules, polyps, cysts, and sulci, I think they will form about 60 to 70% of our laryngology practice. Leaving aside people who do specialized work in, say, different other things, spasmodic dysphonia or paralysis, but these are very, very common conditions. And even as ENT, general ENT practitioners, you will come across that. Now, can you see my screen?
Yes, sir.
Yes, sir.
So I will start with Dr. Gauri. Now, first we will take vocal nodules. The commonest, probably again, among all these, the commonest condition is nodules. Now, just see this video. This is one of my lady patients who came with hoarseness. History of voice overuse or abuse is there. Now, my question is, now this patient's assessment, you have obviously done the history, taken the detail, her professional history, other things. When you come to examination, do you think stroboscopy scores in any way over conventional 90-degree telescopy or fiber optic laryngoscopy? Your practice?
Probably diagnostically, if it's a very obvious nodule with a typical spindle shape or a hourglass shaped gap, diagnostically probably it doesn't make so much of a difference. But we can get a few other bits of information from a stroboscopy which we cannot get on a simple white light laryngoscopy, like are the nodules very fibrotic? What's the status of the mucosal wave? Is there any other condition alongside the nodules which is causing this phonotrauma in the first place, like a sulcus or a scar or something like that? So maybe not so much for diagnosis, but probably for just prognosticating in our mind and talking to the patient.
Dr. Unni, you like to add something on this?
Definitely. I would probably say Gauri did mention all the associated possibilities which are maybe on the rarer side. Usually we get a typical lady patient, a teacher with nodules. So one thing I would probably, what in my practice, what I generally do is straight away, first thing is advise voice rest for a few days, because there's a practical issue that I don't have a stroboscopy clinic every day. So it would probably turn out to be the next week or a few days later. So voice rest, and then I would definitely like to have one look at least, especially for the mucosal wave over that area. So it does tell me in my mind, as Gauri said, the prognosis especially, and of course to explain the patient also, is just not the nodules itself, it's also the vibratory pattern that has been affected, which is because of, then we explain the things about it. So I would say yes.
So let us simplify it. Do you do stroboscopy in all your nodule patients, or you're happy just doing a flexible or a rigid telescopy and then treating him as you fit? Correct.
To me, sir?
Yeah, to you.
Yes, as I said, but not on day one. It may not be on day one.
Okay, so you will call them later for a check stroboscopy. Dr. Nupur, case like this, you'll do stroboscopy in all. You feel some way stroboscopy is going to help you over laryngoscopy? I'll show you the clip again.
Yeah, you can show the clip again. So I do a stroboscopy in all the patients, whether the diagnosis is going to, we don't know what the diagnosis will be. So voice patient, typically I do stroboscopy. And I think besides what Gauri and Unni mentioned already about prognostication vis-a-vis whether it's a soft or hard nodule, there are 2-3 other things I also look out for. Occasionally it's unusual, but occasionally you may have bilateral cysts at the striking zone, in which case in the stroboscopy, the mucosal wave is almost absent over the cyst. Cysts give the maximum amount of decrease in the mucosal wave as compared to nodules or polyps. And sometimes you may have a fibrotic lesion or a cyst on one side with a reactive edematous lesion on the other side. I think these finer points maybe can be picked up better with a stroboscopy. So I do now almost all patients serve flexible high definition stroboscopy and then make a plan for the patient.
Dr. Anaga, you like to add something to what they have said?
I think in my case, I do stroboscopy for all the cases who come to me for any voice related problem. So it is on the day one that I do stroboscopy. And as Dr. Nupur and Gauri and Unni mentioned, we definitely look for any associated lesions along with the nodules. So not only to give a diagnostics, but also to give the further plan up, to decide the further plan of management. It really aids in the management.
I think the consensus is that stroboscopy is important even in a simple lesion like vocal nodule. You can only see the free edge of the vocal cord with a strobe. With a laryngoscope, be it fiber optic or rigid, you will not see that. Mucosal wave, the pliability, the associated features, the striking of the two surfaces, then the cysts, especially epidermoid cysts. It really helps. Sometimes on a cursory examination, you may miss out the epidermoid cyst because the surface, there'll be a very subtle bulge on the surface. And somebody who is not doing dedicated laryngology may miss that out. So stroboscopy is of help, and it's a good practice to do strobe in most of your patients. I think everybody concurs with that. And Divya, do your clinicians in Bangalore send you pictures, strobe or laryngoscopy pictures, or they only send a slip, Mrs. Divya, for therapy, voice therapy?
So it depends on the doctors who are really interested in larynx. They send me the pic, and they even call me to the consultation room to show me the video. There are some who just do a rigid scopy and send me just a nodule. So there are two. Not really all of them follow the same, but if there is, usually you go back and check with the doctors. Is it if I find anything after taking the case history, and if I find if there is any secondary muscle tension, if I find anything of that sort, then I go back and check with them. But otherwise, if it's a straight nodule, not everybody does this.
Dr. Unni, you are raising your finger to say something, or
just one mild academic point, sir. You asked about the ENT surgeon sending pics to her. I remember what I always tell my patients also. Stroboscopy, there's no point sending pictures. It has to be the video only that gives the actual benefit of stroboscopy. It's just a mild academic point.
Your point is correct, but practically what happens is, even if you give a CD, for somebody to open up the CD in a busy OPD, it becomes difficult. So a well taken, even stroboscopic picture, even if you see in this, if I just zoom on one picture, it is, this sort of a thing. You get a fair idea, and you want more detailed information, then you can ask the patient for the CD. But what I want to give a message is, all of us are guilty of that. We have become too busy, and we fail to appreciate the therapists whom we are sending the patients must have a visualization of the lesion. Only then she can or he can give good therapy. Even a single picture is enough, or if you have time and if it is logistically possible, get her, show her, and discuss with them. It should not be done in isolation. Even if you are sending to somebody who is not your regular therapist, at least, because the patient will stay with her longer than you, if especially voice therapy is going on. So how to take feedbacks, how to give feedback, I think you have to have a good liaison with them. Otherwise, there will always be a gap between what you have seen, what patient wants, and what therapist is giving. Divya, you'll agree with me?
Yes, definitely.
Now, next thing is, now, Dr. Annaga, what are the situations where you'll operate vocal nodules? And what percentage? The second part of the question is, what percentage you end up operating? Your voice is not coming, Annaga.
Annaga.
I would say it would be less than 10% of my cases where I would really operate on vocal nodules. Most of them do get resolved with just speech therapy and the proper vocal hygiene and lifestyle modifications. But there are certain nodules which are very unmanageable with the specific treatments such as speech therapy and voice rest. So in those cases, only when it's a very hard nodule, very firm, hard nodule, larger nodules, which is really affecting the voice, in those cases, you would need surgery.
So what is your time frame before you decide to do surgery? You have given voice therapy and conservative treatment for how long?
I would give at least 3 months of speech therapy and lifestyle modification and conservative treatment before deciding on the surgery. And I would, it would be as the patient should ask for surgery, and then I would operate on that patient.
Dr. Gauri, what are your criteria for operating on vocal nodules?
So I would agree with what Dr. Alinga ma'am has said, that it is a very rare case where you would operate on a nodule. More often than not, a patient would be advised surgery by somebody and you would say, no, don't go for surgery, go for speech therapy first and voice therapy first, and exhaustive voice therapy, of course. But the situation I would say that would warrant surgery, of course, is if a patient is relapsing. Every time she stops therapy, she again has a bad voice, and then maybe for a few months of therapy again a little better. It keeps going up and down and not resolving the voice issue really. So maybe that, but I must say it's been a long while since a situation like that has come up where you had to operate a nodule actually.
Dr. Nupur, your
So
take
just
on
to give you an idea of whenever I'm asked to do a chapter or I was doing my atlas on phonomicrosurgery, the one thing I didn't find was operative photos of nodules, and I always struggle to find them. So just to show that how occasional it is that I may be operating on nodules, only when they get polypoidal, where one can actually call them as polyps now rather than nodules, then I would go in earlier for surgery. But nodules really are just therapy, more therapy. And the idea is not to cosmetically have them disappear. The idea is just to get the patient to have a voice without vocal fatigue, which is serviceable to them. And also a word of caution, very often in singers, professional voice users, the character of their voice is actually because of those small nodules which they've developed. So of course they come to you because they've gotten unmanageable and there's fatigue or there's odinophonia. So you want to settle them, and it would probably not be a wise thing ever to operate on them because their character may also change, that little raspiness which is there or a little breathiness. So we have to be very careful when it is singers and professional voice users.
So polypoidal nodule, yes, that I'll agree that if they, and these regions do fleet, they do change from one form to the other. We call them podules, polypoidal nodules, we call them podules. But firm nodules, if you see, you've done a stroke and after 6 weeks, patient comes, you see the nodules have grown in size, they have become firmer. You've done a stroke, the mucosal wave less well appreciated, the pliability of the cord fold is less. So is that an indication in your dictionary?
When it's a very hard and firm nodule with very poor mucosal wave, even then I would go in with 3 months of voice therapy for certain. And then in that situation, if my therapist says the patient has been very compliant, has understood the therapy, I'd go ahead and operate. The reason just being that I don't want a recurrence and the patient and me also getting disappointed with it. So, yes.
One more thing I like to add is associated muscle tension dysphonia with nodules. So if you have given therapy for 6 weeks, 2 months, and still patient's voice is not good, don't jump on to operate the nodules. Try to correct the muscle tension dysphonia. Divya, your comments on this? Treating muscle, and how will you do it?
So simple nodules usually get better by 6 weeks. I have seen all my patients getting better by a week or 10 days. They get back to me saying they feel better if it is a just clear nodule. But if there are associated problems like a secondary, because if the diagnosis gets delayed, then they develop muscle tension dysphonia. So once we treat that, then it will take a little longer. But I think 6 weeks to 8 weeks, it should be fair enough for a patient to feel better with the voice handicap index that they feel pre and post therapy. They'll be able to appreciate their voice better. So, and I also do these acoustic voice assessment so that, pre and post we have the data and the biofeedback for the patient also to understand where they started. So these things I make a note of it, and it usually it is 100% curable, is according to me.
So which software are you following in Bangalore?
Basically Pratt, that's what we do. That's a normal thing. Otherwise, if you are a sophisticated institutions, you can do Wagmi, Doctor Speech. There are multiple things that you can do, and you have
were
lots
doing
of time.
Doctor Speech in Vedanta. You were doing
Yes.
Oh, yeah.
Doctor Speech, yeah.
Now, question again to you. What sort of therapy will you give for these vocal nodules? Since 90%, everybody agrees, all clinicians agree, it is your domain. So what therapy? Can you elaborate? And some clinicians may like to know what are at least some basic exercises which you'll give.
Basically, it's a target of the physiological changes that happens with the nodule. So, like for example, if you're in this picture, there is a phonatory gap. So I would directly work on the phonatory gap. I would also work on the strengthening of the muscles so that they don't, as they said, there can be relapse. So if you work directly on the strengthening of the muscles, then there are less chances of relapse. And also the behavioral modifications like the vocal hygiene tips, like the reflux changes and the environmental changes, not shouting, screaming in a noisy environment. So these modification is one side, that is the behavioral changes, and the secondly directly working on the physiology. That is the sometimes the breathing pattern may not be right. They don't take in a good adequate lung capacity will be less. So they use a paradoxical breathing or a shallow breathing. So we work on the respiratory pattern, then we work on the direct laryngeal system, and also on the resonatory, how to project their voice better so that they don't strain their voice directly on the effort on the laryngeal system reduce. So that's where the straw phonation and that's the lax vox kind of therapy has come into play these days, that they learn to project the voice better with their resonatory system, that is their oral mechanism, than the laryngeal system. So these are the direct work on the system, subsystems of voice that I do.
Right. So here I like to add the clinician should also have a perspective of what the therapist is doing and understand the set of exercises which are being done. Then you can probably treat these patients better. Now this we've already covered, so I'll only take comment from Dr. Unnikrishnan since he did not speak on this. Muscle tension dysphonia secondary to vocal nodules. Anything you want to add?
Just that main thing from my side would be the counseling of the patient that this is the aspect of muscle tension dysphonia, and usually what we have in the voice clinic is my voice therapist also will be there when the stroboscopy is being done. So usually it's a counseling, so extra aspect of counseling about the MTD. So nothing else.
So just an incidental question to any of the panelists. Has anybody ever done Botox injection for MTD, especially type 2 MTD? Dr. Nupur?
Well, of course, it has been described in very challenging cases. And there was a patient who had come from Africa who we were almost going to do it, but then he didn't need it because he agreed to stay behind in Mumbai for a while for longer sessions. But not done it, but it has been clinically described.
So I have done in 2-3 cases where the nodules were being given therapy. It was decided they'll undergo therapy, but results were not so dramatic. And there was a clear-cut type 2 MTD. So we did inject Botox and the patients were better. And it is described in literature. So even for MTD, let the voice therapist have the first go. But if it doesn't, then that's an option. Now, associated question. Dr. Annaga, any experience of either steroid injections or Botox injection into the nodule?
It has been certain early lesions such as vocal nodules and for vocal polyps. There have been various papers for intralesional steroid injections. But I have not done any so far for these. But I have seen many when I was in MEE. I have seen steroid injections in office. Steroid injections been given for early vocal nodules and for early vocal polyps. Botox injections, I don't think I'll agree with Botox injections for, for your previous question as muscle tension dysphonia, because finally it's the patient's efforts that he's putting in. If he's not using his false cords or maybe the false cord, he'll use something else to give that extra strain pattern. So I would not agree for Botox injections for vocal nodules per se, maybe for granulomas and
See,
others.
those two situations are different. There we were talking about Botox into the false cord for MTD. Here we are talking of Botox into the nodule. Now,
into the nodules. Oh.
Yeah, into the nodule.
Oh, okay. No,
Dr. Gauri, any experience or anything you want to say on this?
No, sir, no experience, neither with steroid nor with Botox injection. But actually, can I ask a question which
please.
Later? So if you do give Botox for muscle tension, does that hamper the voice therapy that happens that the therapist is, or you don't do therapy for that period?
You don't do therapy. The idea, if I may take the question.
Yeah, please.
So when we give, this is actually described for very refractory cases of primary or secondary muscle tension dysphonia. And the idea is for at least 6 weeks to 8 weeks, no therapy is given. It's like giving a compulsory kind of voice rest, and you let the area get quiet. You let the edema around the nodule settle down. That's the idea. And then you start the therapy to not have the wrong compensatory techniques develop, which is what Anaga was referring to. So there is a science behind it, and it's helped refractory cases. My only point, Dr. Handa, was I think the injection of Botox is described as in the thyroarytenoid muscle, even for nodules, and not into the nodule per se, because the idea is to not allow the
Make it flaccid. I agree with that. That is correct. The Botox should be into the muscle. Steroid is into the lesion.
Yeah.
That is correct, but both have been described. I have never put Botox for nodules. Steroid injection, we have done 1 or 2 cases where there was a high pressure demand from the patient to do so from medical background. There are people doing steroid injections as office-based procedures get more popular. It's a simple way of, and patients don't want to take voice therapy. They don't want the hard way. So they have read about steroids. So it's all right if somebody is injecting steroids into nodules for a faster recovery in office space. Botox is an exception, but it is being done. There is literature who have made the cord flaccid, because why do nodules develop is because of the contact area, voice abuse, anterior 1/3, posterior 2/3, the contact area. So if you make the cord flaccid, that area will not be there, and with the hope that it will reverse back. But I have never done this myself. You have any experience, Dr. Nupur, for Botox for nodules? No.
No.
It's only a thought. See, we can always take cues from what people are doing and then apply, whether it is possible or not. Now we come to vocal polyps. Dr. Unikrishnan, polyp, vocal cord polyp. What do you prefer?
Laser, so the question for me is,
yeah,
null and void for me. I'm using cold steel only.
Sorry?
Cold steel.
Is it, you have a laser in Amrita or no?
Oh,
so it's fine. If you don't have, it's fine. I know what Dr. Nupur will say. Dr. Annaga? What do you prefer, laser or cold?
I would prefer laser whenever a good laser is available. But if it is not available, I'm equally comfortable doing it with cold steel.
Fair enough. And Dr. Gauri?
I also prefer the laser because we do have the laser available for polyps especially.
Yes. I remember Niti Clinics had a laser long time back, some 10 years back also.
Yes, sir.
You had a workshop and there was a laser there. So yes. You have a laser and you prefer a laser. Dr. Nupur?
So I just want to add, of course, you know that I do everything mostly with a laser, but very often polyps do have a feeding blood vessel, the hemorrhagic polyps especially. And then it becomes a little bit of an added advantage because you can laserize the feeding blood vessel and prevent the recurrence. Yes, I'm using laser since we have an AccuPlate system.
So I think there is nothing wrong with using cold steel. You can do a good job with cold steel, but if you have the laser, there are definitive advantages. The ease of cutting, you are cutting with 100 micron precision, and anybody who tries both knows the difference. The hemostasis or the welding of the vessels, small vessels on the surface, that is an added advantage. So if you have a laser, use a laser. Here, I will use a stationary laser that is under GA CO2 laser. Karen talked about blue laser, office-based procedures. It's fine. But again, if you want to do a very precise job, it has to be under general anesthesia. Nothing can beat a stationary patient under a microscope and you feel well, you are able to cut correctly. If any office-based procedure, you are using a forceps, you are using a biopsy forceps and plucking out the lesion. So it can no way match what you do under general anesthesia. I don't think anybody has a doubt on that. So you can do if there are anesthesia problems, patient not willing, there are situations. but the precision can never match a GA under a laser under general anesthesia. Yes, Dr. Nupur, you want to say?
I loved Dr. Karen Cross' talk, was fantastic. What I just wanted to mention here is we always have to remember the situation and country we are in and the challenges which we face being different from the challenges the West face. Sometimes you feel that the West has no challenges, but that's not true. You just heard Dr. Cross say that it takes 1.5 years for a patient to get to a gastro. Now, a patient in India will take 1.5 days in the maximum. So very often they have challenges of not being able to take the patient into the OR, a patient with a hemorrhagic polyp. We don't have those challenges. So we don't always have to ape what is happening in the West. We have to decide what we want to do and why we want to do it. That's just what I wanted to add.
Very correct. In Canada is again a national health system, which is slow like UK. America is different. America, it is more to do with economics. The office-based procedures, they probably suit the clinicians better. There is nothing wrong with that. They do a wonderful job. But in India, even since you can cut down your GA cost, and personally, we are most comfortable doing under stationary, under general anesthesia. Unless anesthesia problem, patient not willing, not giving consent, and wanting to be done under local, then you will do under as office procedure. Yes, Uni, you were wanting to say something?
No.
Fine. Now, what Dr. Nupur
I just wanted to add something.
Yeah. Please, Dr. Anaga.
Yeah, just a word of caution for the younger colleagues and the younger laryngologists is that it's not always mandatory that you have to have laser. It's not that even if you, you should have a good laser with a good scanning system and a very good precision. So it is whenever you opt for laser, you see to it that you have a good laser. Otherwise, it's better to do with cold steel than use a laser.
I entirely agree with that. If you want to use a laser, use a international standard. All of us, you use luminous laser. There is no point using a diode laser on the vocal cord. You will scar the cords for life. Then it is better to do your either microsurgical dissection using adrenaline hydrodissection, or even otherwise. You can do a neat job with the cold steel, a better job than a bad laser. Just because laser, the word is there, you don't have to use any laser. Now, this lesion, Dr. Gauri, how will you address this polyp?
So, sir, again, if we are talking about using a laser, then yes, with a laser, we will do a mini, like an incision right on the lesion, as close to the lesion as possible. Is it really a polyp or whether it's subepithelial? I think once we make an incision, we might find that out because it's looking a little pale white. Maybe it's a cyst that is popping into the glottis. I'm not so sure. But after taking the incision and then by elevating the epithelium off, with cold instruments, if it's a cyst, of course. Otherwise, just with a with a lateral incision and excise it with the laser. Cyst.
Dr. Anaga?
Yeah, I would prefer the laser in this case. And yes, I would, before taking an incision, I would always do subepithelial infiltration with saline adrenaline so that it will not only help me protect the underlying superficial lamina propria, but it also will aid in preventing any further the energy being transmitted to the deeper delicate layers. When using a laser, I will use the microsurgical techniques instead of just excising the laser with excising the lesion with a laser. I would take an incision with an AccuBlade, dissect the polyp off from the underlying SLP. And it is very difficult to do a microflap technique in this case because it seems to be firmly adherent to the epithelium. But at least you try to preserve the undersurface of the lower part of the epithelium in this case, so as to give a proper mucosal covering to the post-operative wound.
So let us understand the lesion. It is it's a polyp which is broad-based. The attachment is broad. And Dr. Nupur, your take on this?
So the first thing I like to do in any lesion of the vocal fold after getting the microscope in is palpation. I think that gives us a lot of added information, because I agree with Gauri, just looking at the lesion, it was difficult to say. Once we palpate it, we know, is it fibrotic, is it firm, is it cystic, is it just a polyp? So I palpate. At the same time, always palpate to see are there any sulci or mucosal bridges that we are missing out, because in our series, we found that almost as high as 60% of sulci and mucosal bridges were found during palpation. Then, of course, all the steps of the surgery remain the same. And I agree with Anika that there's no sense really trying to preserve any kind of overlying epithelium in a large lesion like this. There's no point. All that epithelium can come out, which is adherent to the lesion. And what we want to save is the infraglottic epithelium. That infraglottic epithelium will then drape the medial vibrating edge. And of course, I always use infiltration. So the basic principles of phonomicrosurgery being applied, and to see that you have a minimum raw area at the end of surgery. That would be my take with a lesion like this.
How will you address the blood vessels on the superior surface? Will you do anything? Not on the lesion, on the true cord. Superior surface.
So if we notice there are blood vessels on both the vocal folds, especially anteriorly, so whichever varices or dilated vessels are actually going towards the lesion, I would spot weld them. Not the entire length, but just spot weld them.
Right.
But I wouldn't go to the lateral edge, etc., trying to get some kind of a cosmetic appearance.
So if you see the feeding vessels, if you can identify, if you just weld them, that should suffice. That should suffice. The other thing is, note the jet catheter. This is the jet ventilation. This is what we use. And the whole airway is yours.
This is the Hunsaker distal jet ventilation?
This is AcuJet.
Okay.
AcuJet. This is one of the best companies. And we normally use a subglottic jet, unless there is a problem in the, there's a stenosis cases where you can use a supraglottic jet also. But most of the times we use this subglottic jet.
So every MLS case is being used, sir?
Most of the MLS cases, unless there is a chest problem.
Very.
Yeah, so it is very helpful. About say 80 to 90% of the cases, we are able to work with this. Now, Dr. Gauri, somebody's gifted you this patient. Now, how will you deal with this? There is history of voice overuse, badly hoarse. He wants his voice corrected fast.
Yes, sir. So there's obviously, we can see a lot of subepithelial hemorrhage happening in this vocal fold. So I would like to give him a trial of conservative management first with steroids and anti-inflammatories. But of course, there is a small lesion that we see at the anterior part of the vocal fold. That lesion is probably which will require surgery. After giving a proper course of conservative management, then we shift to the OR to tackle the anteriorly placed lesion, which is probably a subepithelial cyst, perhaps.
Patient is pressurizing you very much. He wants his voice back, has to perform. So Dr. Nupur, your take on this?
I totally agree with everything Gauri said. I would want the hemorrhage to settle. With a lot of hemorrhage, the fibrosis increases. So I would give IV steroids to the patient, 1 or 2 shots, want the hemorrhage to settle. If it becomes even little pinky yellowish, where you see hemocedrin resolving hemorrhages, when I'll go in for the surgery with microflap, I think possibly there is a subepithelial cyst anteriorly.
Patient has come from far away. He has an old recording which showed only this lesion. This hemorrhage is recent, history of some voice abuse. But he is pressurizing you. I have to go back.
Admit IV steroids.
How long? IV steroids for how long?
2 days. And then when I make the incision, I won't be laserizing all the blood. I'll just make the incision, do the surgery. I don't even feel there's a role of any injection of steroid, because when you make the incision, the steroid doesn't really stay. And post-operatively give steroids for maybe 1 or 2 days and then switch over to chimeral fort. Maybe give voice rest for 10 days to 12 days rather than just the usual 7 days, which I give.
Dr. Annaga, anything different from the first two?
I would not be comfortable operating on this patient with the hemorrhage in place. So I would definitely confirm with a laryngoscopy that the hemorrhage has resolved. If he's pressurizing, maybe I'll refer to someone.
Pressurizing is very subjective.
No, it's not pressurizing that way. Pressurizing is he's come from far off. He wants his surgery
But
done.
the only thing is, I think, to explain that
Yeah.
the surgery is
It will definitely add on to the problems if you operate with such amount of hemorrhage.
By the way, is everyone convinced that's a cyst there? If it's too anterior.
There is a cyst. There is a cyst. It's only a still picture. There is a definitive cyst, and it turned out to be a cyst. He was operating. See, I entirely agree. Ideal is you wait for the hemorrhage to settle down, then operate. There is a cyst. But if it is an emergency, emergency being patient has come from very far off, the logistics, the cost, and you have to operate, and he wants his voice back badly in a short span, then IV steroids, as Dr. Nupur said, and maybe you operate, only address this part. Don't do anything at all to the hemorrhage. And it is a slightly inferior option to the first option, but if given you have to do it, then just address this part. Don't weld these vessels. Don't use your laser on this. Just let it stay like that. Give steroids. Even you can give oral steroids also. IV is only during the span of his staying with you. Once he goes back, maybe a tapering dose of for 3 weeks should set him right. And we had to operate.
Also, Dr. Hannah,
yes, please. So we did.
We do have to remember that patients who they don't resolve with steroids, then what would you do? You give 1 week, 2 week steroids, and they don't resolve. So we do have to do surgery on them using the same principles that we discussed.
So for various compulsions, I had to operate on this. This was we did take out this cyst. It was a cyst, but the hemorrhage is as it is. And he was put on steroids and including your Zinase D, Chimerol Fort, and he came back after a month. Cord was perfectly normal. So at times you have to tailor-make the situations, but understand what to do, what not to do. Now, Divya, any role of voice therapy for vocal polyps? Mostly surgeons will not send you these patients, but suppose some patient does come to you.
Yeah. So one role of voice therapist here is pre-operation counseling to the patients regarding the surgery and whatever the voice rest and the vocal hygiene that they have to follow post-operative. That is one that can happen. And there are cases who very soft or a very early polyp or a very translucent that they I think some ENT I'm not too sure if they have a doubt on whether it is a polyp or a nodule. So in those conditions also I have received patients with polyp, query, vocal polyp, those kind of diagnosis. So we try with speech therapy and see if it resolves or not, and then maybe after couple of weeks, maybe 4 weeks, we understand if there is no change, then I refer them back to the ENT. So there are a couple of patients like that, but yes, I get a couple of patients, but I also work on the secondary muzzle tension, basically because we get a lot of diplophonic voice. The false chord vibrations would have already started because usually they come, the diagnosis will be a little later. So usually the dysphonia plica ventricularis will be there. So I work on that also, so that at least some symptomatic relief happens.
Dr. Unni, any polyps will not operate?
Yeah, so not exactly voice therapy. Very small polyps have definite experience with resolution with just basic voice care measures, not exactly voice therapy per se. The voice rest and just following up after a few days, we definitely experience with the rest of small polyps. So at the outset, the first, I sometimes tell that there's a chance of things, provided there's good voice care taken. Not a formal voice therapy. I may not.
Dr. Unni, our question is, what are the type of polyps you will not operate, or are there any polyps you don't operate?
Yes, so So on day one, it's very small, but there is a chance of resolution with conservative measures. That would be one. Follow up the patient.
All polyps which are coming to you are first and doing conservative treatment.
Small ones, small.
Small size. So you go by the size of the polyp. All right.
To resolve just since the
Dr. Annaga?
Otherwise, hemorrhagic polyp definitely.
Okay, Dr. Annaga?
Yeah, most of the polyps do require surgical management, but there are certain like those are query polyp, or is it a nodule? Like early nodules look quite polypoidal with the reactive lesion on the other side. So whether it's just a very early nodule or it's a polyp with a reactive nodule, when there is a doubt, you will definitely give voice therapy and speech therapy first before recommending surgery for such a patient. And for any polyp, you would not, I mean, I think we'll be coming to that later on, but voice therapy will be required to sort of correct the maladaptive compensatory patterns that the patient has developed, as well as for learning how the patient needs to speak after surgery. So a voice therapy is mine. I give voice therapy for all cases of polyps, but voice therapy as per se as the management, I would give for very early polyps who may be looking like vocal nodules or very early polyps.
Dr. Nupur?
The only polyps I give a conservative line of treatment is when the patient comes with a very acute history, very short history, and I see a hemorrhagic polyp, in fact, which is maybe a small size. I would definitely give them steroids, voice rest. And if that polyp becomes white very quickly and the hemorrhage goes away and small, those polyps we actually start on relaxation therapy and voice therapy and conserve. That's the only type of polyp which we try to tackle without surgery. All the others really go in for surgery with post-op voice therapy.
I think most of us will follow that. Polyp is a surgical entity, mostly treatable by surgery, unless you are not sure of diagnosis. It's say polypoidal nodule. It's a confusion between a retention cyst, mucous retention cyst, and a polyp, or the patient doesn't want surgery. This is a situation which happens. They just come to you. We come for treatment, but we want no surgery. Fair enough. We tell them we'll give you trial of 6 weeks, 2 months. You satisfy yourself. That's an odd situation, but primarily it's not like nodules. It is a surgically treatable disease. I think there should not be any confusion on that. Now, this is for Dr. Gauri. You see this lesion?
Yes,
you can make out, yes. And there is a sulcus on the other cord. Again, it's a still image, but the video clip, there is a small grade 1 sulcus on the other cord. In fact, the sulcus is there on the side with the polyp also. So what do you do to this patient?
I would just, if the history of the voice, the duration of the voice problem is not for many, many years, then probably I will just at the first stage go for excision of this polyp, see how the voice is, give them post-operative voice therapy. Of course, pre-operatively, I would be explaining to the patient that you probably also have some sulcus, which we can confirm intraoperatively during palpation, like Madam mentioned, Nupur Madam mentioned that we would palpate every patient before actually starting our surgery. So if we do find a sulcus, I would not treat it in the same sitting, but I would give the patient an idea pre-operatively that you might have another pathology which we can treat later depending upon how your voice is after surgery and after therapy.
So Divya, Gauri has taken out the polyp, decided not to operate on the sulcus, send the patient to you. So how will you manage this patient? You are left with a patient who has at least grade 1 sulcus on both the cords now and a surgery done a week before.
Okay. So maybe a 1 week of voice rest post-op, and then start off with the glottic closure exercises for the sulcus because there will be phonatory gap, and work on the vocal fatigue and relaxation exercises. Because of the sulcus and the polyp, there could have been other compensatory muscle movements. So work on those aspects.
Dr. Nupur, any different approach to this situation?
No, I totally agree with what Gauri said in terms of removing the lesion would give a good result. But we do keep in mind that sometimes these lesions are compensatory because there's a bilateral sulcus and phonatory gap, and the body is trying to compensate and develop some lesion. So I would palpate, definitely. And if I feel the sulcus is deeper, I would like to address it because it would then help in the prevention of recurrence. It would help the therapist to do a better job. So a lot would go by the palpation of the depth of penetration of the sulcus.
So I think everybody agrees you cannot address both in the same sitting.
I just want
please, Dr. Unu.
Ask a question sort of to Nupur especially. So this is, I assume, sir, has shown a on-table pic. My question was, it's a OPD situation. We have done a stroboscopy. What would the counseling be? Would we say upfront that it is going to be a staged procedure? Polyp out first and may need sulcus surgery later.
Only what I tell my patients is that the lesion will definitely come out. I'm going to be palpating the sulcus, and if it is deep, I do not keep it as a staged procedure. As you know, we've described the surgery called the LASR, the laser assisted sulcus release. And we've been getting very good results with it. So if it's the sulcus, which we feel there's a depth into the SLP or going into the ligament, we would do a laser-assisted sulcus release at the same sitting. We've even done that bilaterally. As long as you respect the anterior 3 millimeters, there's no issue at all. So we just warn the patient that the healing will be much slower when we're operating the lesion as well as the sulcus, because when you're releasing it, the epithelium has to regrow wherever the cuts have been made, and that would take a minimum of 6 weeks.
So I think...
so we take that consent.
So most of us will stage it. We will do the polyp and then do the sulcus. But Dr. Nupur's approach, and I think there is nothing wrong with that. Only thing is the patient's expectations and making him... what I'll do, I'll show this lesion to the patient. These are the 2 problems you have. And first thing is very easy, but the second surgery will have, this is the amount of voice. If your normal is 10, I can get it back to 7. I cannot get it back to 10 out of 10. He has to be counseled for any sulcus surgery. And personally, I will stage it. I will not do it in the first go. But if it's perfectly fine, if somebody is attempting to do it in the first go, especially there is a narrow base. If you see on the same cord also, this polyp, it's not a broad-based polyp. It's a narrow pedicle polyp. So even if you cut it off, you can work on the sulcus. Now, this is for Dr. Gauri, a professional voice user, comes to you with this lesion. What do? Surgery, no surgery? Voice is bad, very high expectations.
So again, like we discussed with the previous patient, if it is a very acute history or very short duration where the voice has gone bad, we can try a conservative management. But conservative management, of course, being steroids and anti-inflammatory drugs to hope to settle down. Of course, the size edema of the polyp would go down, and the lesion would also probably go down, and also the coincident edema, hemorrhage that is in the vocal cord around it, especially if this is a professional voice user. Again, we have to counsel the patient that this is a lesion that will probably require surgery. But initial stage, we can try a conservative management and then go ahead with surgery if that has not solved the solution.
Dr. Anagha, do you think this lesion will go away with conservative management?
This looks like a very large hemorrhagic polyp, and which is pedunculated. I think it must be flopping in and out. So I would definitely, I think the patient definitely requires surgery in this case. There are a few subepithelial hemorrhagic regions which may resolve with conservative management, but personally, I don't think the polyp will resolve with conservative management, will require surgery.
Yes, I agree that surgery will be needed. Most professional voice users take a little bit of time to finally come in for the surgery. I would use that time to definitely give the steroids, have the angry look go away, and then do the microflap surgery.
So I think consensus is it needs surgery, but don't rush for surgery in the first go. Let the patient understand, because you are going to touch a professional voice user, and he must earn his surgery. we are very slow in, even I date them. If my normal waiting is 15 days, I'll give this guy a 1 month's time. Let him think over. Don't rush in to do surgery. Let them understand, let them ask you questions, and let them on their surgery. Because they can, if there is some voice change beyond their expectations or not up to their expectations, you will face these patients for a very long time. So have a conservative approach, but I don't think there is any way this lesion can go away with conservative management. Divya, can you correct this lesion with the voice therapy?
I doubt.
Okay.
This seems very challenging to me. But we can play a role in counseling the patient and getting them into the right mindset to get to the surgery. That's the role. And then post-op, definitely till they achieve their finest voice, they usually like to come back and get it corrected. So I've seen a lot of professional voice users, they just don't get satisfied with a normal voice, normal how we treat other patients, but they really want the finest voice. They touch all the pitches and the loudness they can, and timbre, everything. They want it in perfect shape. So that's like a challenge.
Now, before we come to Reinke edema, the news in the India-Pakistan matches, India has won the toss. And they have
won the toss, lost 2 wickets, 17 for 2.
Lost their opening batsman.
17 for 2 in 4 overs.
2, okay. So
both Shaheen Shah,
stay with phonosurgery. Don't go for cricket right now. We'll be fast now. Now, Reinke edema. Yes, Dr. Nupur, please.
No, I know you said we'll be fast, but I just wanted to add that all our professional voice users, after 4 weeks of speech therapy, then we switch the patient over to the singing therapist and start singing therapy. And for most of the singers, we counsel them that they can restart their shows at 6 weeks from surgery because they need to have some expectations in their mind.
All right. But see, regarding these singers, we must be firm with them. We have to define how much can they sing. Yesterday, I had about 40-minute, one of the longest discussions with a professional singer. She is in, there is a dancer called Sapna Chaudhary, she's her singer is the one. Now, she has a bad lesion. She has committed her shows and she doesn't want to stop. She doesn't understand the consequences. She has probably taken advances or committed. So that mindset, you have to be very firm with them. So what I could negotiate is she has committed some 10 shows in next 20 days. So I cut it down to 5 shows. That's all. But you have to be firm. Don't be too polite. Don't let them their way. Otherwise they'll blame you. So, and they need time. These professional voice users, if your normal patient, laryngology patient needs 10 to 15 minutes, they need at least half an hour. The expectations are high. The problems are very specific. Now, Dr. Gauri, this lesion,
Yes,
a
sir.
lady, 40 years old lady, comes to you, voice abuse is there.
Okay. This is obviously Rinke's edema. You mentioned that this is a 40-year-old lady, but of course we would like to rule out all the predisposing factors for Rinke's edema, make sure her thyroid levels are fine, she's euthyroid, and if there is any smoking history, then that needs to be corrected. But this would again be a case that needs surgery, if of course the thyroid hormones and the levels are normal.
Thyroid is normal. It's a very good point. Hypothyroidism can give a similar picture. You may not get such a thickness of the cords, but a lot of times where the cause is hypothyroidism. If you have to do surgery, Dr. Annaga, how will you approach? What will you do surgically?
Yeah, I would opt for surgery. I would opt for surgery only after giving a course of steroid and seeing with this course of steroid whether it resolves. If it doesn't resolve, yes, I'll go in for surgery. I would definitely like to use a laser in such a patient and use a phonomicrosurgical technique that has taken incision on the lateral aspect of the lesion, suck out the SLP, the extra SLP which is there, and trim the epithelium so that you can redrape it well over the exposed wound.
So I guess you are referring to the superior surface. You do a cordotomy.
Yeah, I would take an incision on the superior.
You've done a cordotomy, but you're not able to suck it out. It is a myxomatous sort of a change. So then what do? You give a incision like this along the length of the cord, shorter length of the cord, and you put your suction. You're not able to suck it out. It is myxomatous.
Yeah, if it is not a suckable, I mean, if it cannot be sucked out, then I would excise the lesion like I would do it as a polyp. But only thing, if I'm and save the intraglottic epithelium so as to redrape the wound. The only problem in this case is that we have to be careful when you go to the anterior commissure, because if we are doing bilateral excision of the lesion, which is extending to the anterior commissure, there is a chance that you may create raw areas and cause a web post-operatively. So you have to be very careful when you're going to the anterior commissure and try to preserve the epithelium at the anterior commissure level.
Dr. Nupur?
So did you mention whether this is a male or female and whether it is a
female, but not a smoker? Voice abuse is there. Given conservative treatment, including voice therapy, including a course of steroids.
Right. You said female, right? Sorry, I couldn't hear. Okay. So first of all, I don't really believe in giving steroids. I would like to actually treat the patient for reflux for a good period of time, 4 to 6 weeks. If it's not a smoker and the thyroid profile is normal, reflux can occasionally cause this kind of a picture. So I wouldn't want to give steroids for that reason. And I would also change the behavior pattern of vocalization. So I would have relaxation therapy come into the picture. With a grade 1, the voice is typically not very bad, so we can wait. If that doesn't give any kind of improvement, I would go ahead with the surgery exactly how Anagha kind of described it, by making 2 incisions, but not going up to the anterior 3 millimeters. And typically we use small patties with a thread attached, and we kind of squeeze the material out, because it's very often it actually doesn't get sucked away. So rather than laserizing all the SLP, we like to take the patty and kind of squeeze it out from the epithelium side like a toothpaste. We have to be careful not to make the vocal folds too thin, even though it's a female, because otherwise you can get a little bit of a Mickey Mouse kind of very high-pitched voice. But that would be how I would tackle it, yeah.
Yeah, I think the message is, you do a superior cordotomy. If you have a laser, fine. Otherwise, do with a cold steel. Try to suck out. Most of the time, you may not be able to suck it out. It is myxomatous thing. So Dr. Nupur's technique is perfectly all right. Use a patty to express it, or in a very low power setting, keeping the epithelium intact. Subepithelially, you can do defocus mode mein laserization. Taking care, you are medial. Obviously, your lateral vocal ligament is the landmark, and try to subepithelially reduce the cord structure. I have done in few cases. It has worked well that way, but I will not advise cutting the full cord like this, because you are going to leave a huge raw area and on both the cords. Apart from the web, which is one issue, the other issue is the phonetry results will never be so good. It is too much of a surface area to be taken out. So do whatever you want to do subepithelially. First, try Dr. Nupur's technique, pressing it out with the patty. If you can, fair enough. Otherwise, defocus mode, low power setting, 2 watts, subepithelially, you can reduce this. But don't make the whole area raw. Now, yes, Dr. Uli, you want to say something? Yeah.
Yeah, I just said, I had experience with one very difficult case, severe Reinke edema, a male smoker. So after all the conservative, I did the surgery on one side. For the non-laser people, I actually use small cup forceps to actually take out this thing. So like jam, the best example was really scooping out jam.
Jelly, more like a jelly than a jam.
Jelly, yeah, jam, yeah, jelly. And just for the
jelly and jam are different. Jelly is
jelly.
It is like
Yeah.
orange marmalade. Marmalade,
Yeah.
you know, orange marmalade. It is more like orange marmalade.
Yeah. And redraped well, and patient was, I did only one side because the fear of to observe, and patient was quite happy and of course stopped smoking. So till about 6 months, did well.
But problem is, if you just do on one side, this sort of a lesion, it will not suffice. The voice will not come back. I think you'll have to reduce very carefully both the sides. Dr. Nupur, one side, both sides.
No, I would address both sides because I think symmetry is exceptionally important for phonation. That may be staged or unstaged, but I would like to do both sides.
Okay, now we will come to this. This is Dr. Gauri. Please see the lesion.
Yes, sir.
So how do you
one diagnosis where, of course, surgery is the only option for treatment, and this is the one case cyst where I don't use the laser. I do it only cold steel. I know some people take the incisions with the laser. You can do that, but yes, surgery with microflap, mini microflap technique, taking the incision as close to the lesion and then elevating the overlying epithelium, then separating the cyst from the underlying SLP, making sure to cut its attachments, thick attachments, both anteriorly and posteriorly. And then if there is a lot of redundant epithelium, we might need to trim it. And as was mentioned with one of the previous cases, we need to make sure that we have enough infraglottic epithelium that is preserved to drape over the subsequent raw area. And post-operatively, of course, voice therapy.
Say it is your bad day that day, you ruptured the cyst, then what do you do?
With cysts, most days are bad days and you end up rupturing most of them. So yes, but if possible, the point where it has been ruptured, and especially if it's a decent size, good size cyst, the point where it has been ruptured can be grasped with the forceps, and then you can still complete your dissection as cleanly as possible.
No, my question is, if you ruptured the cyst, will you just leave it marsupialized? Will you do a complete excision, or you'll do a excision leaving some mucosa, as you said, infraglottic?
So like I mentioned, sir, if it is possible to still kind of get a hold of the cyst from the point where it has burst open, still kind of get a hold of it and then try to remove it intact. Otherwise, marsupialize. If it is too small to be then held, then yes, you end up just marsupializing the burst cyst.
Dr. Unni?
The first thing I just wanted to say was I do not usually infiltrate. I've stopped infiltrating these cases cysts because it tends to blow up the entire thing and lose my landmarks. That's the one thing. And about the bursting, the one point, if your burst is not to suck on it so you completely lose it, so gently swab it away with hemostatic pate and then see if you can still identify the lining. If it's a small one, it probably could be marsupial. Otherwise, I would still try to gently tease away the and do the dissection.
Dr. Nupur, your final word?
Since epidermoid cysts have a capsule lining of stratified squamous epithelium, even if we rupture it, and in my hands also 30% of the times I open up the cyst, it is not difficult to identify the cyst wall because it's thicker. One must remove the entire cyst wall because marsupialization doesn't have much role. It will tend to recur. And there lies the beauty of the laser, I must admit once again, because then you can just laserize all the suspicious cyst wall. So it's good to have that in your armamentarium for the burst cyst.
So I think we'll all agree with that. A epidermoid cyst is a different entity. It must be excised in toto. If you rupture it, don't feel bad. It happens with almost everybody. You have to excise the full cyst. The wall is thicker. Laser can be used not just for superior chordotomy, even for dissection. With a fine, if you have a acu blade, you can very nicely take out even a burst cyst. In case it is not identifiable, then you at least fulgurate it. Put the lateral limit as the vocal ligament, define the vocal ligament, and medial to that, you can fulgurate it. Here, even if you have loss of mucosal epithelium, the medial epithelium, it is still better than leaving some part of the cyst because it will recur. I think that message should be very clear. Whole cyst should be excised, even if ruptured. There is no role of marsupialization. I think, and voice therapy, Divya's role will be for compensatory hypertrophy. For primarily cyst, epidermoid cyst, there is no role.
Correct.
Only catch in this is a lot of times it is missed, especially this cyst is very clear because the color difference is there. The cyst shows over the the translucent epithelium. Sometimes there is no difference. It's only a bulge. So as you grow in the specialty, you must learn to identify a cyst. One should not go wrong. There can be a very subtle bulge, voice is bad, but with experience and the role of stroboscopy. Here stroboscopy will help. And you handle this cyst. Now, mucus retention cysts, Dr. Annaga, anything different?
No, I would deal with it in the same way as in these cases such as this, as only mentioned, that I would not inflate because it just blurs the margin of the cyst and it gets difficult to identify the lateral edge of the cyst wall. And if laser is there, I would actually use both laser and cold steel when I'm using operating for cyst. I would take an incision with a laser, dissect subepithelially like with the microflap technique. The cutting of the anterior and posterior attachments of the cyst is very easy with the laser, so I would use laser for that. Because sometimes using a scissor is very difficult in that space. So laser is a very helpful tool in disconnecting the anterior and posterior bands. And I would definitely try to preserve the entire epithelium by using the microflap technique and repositing it back after excising the whole cyst wall. In total, of course.
Nupur, anything you want to add for mucus retention cyst?
I just want to add two technical points during surgery when we use the laser and that anterior posterior fibrotic band, what we call the pearl on a string kind of thing. That is the only instance where the laser actually beam is going to be at 90 degrees to the vocal fold. Normally, we always have the AccuBlade parallel with the vocal fold. So it's a good idea when you're cutting the anterior and posterior fibrotic bands to decrease the length if you're using an AccuBlade rather than 1 millimeter, make it 0.5. Otherwise, the length is so much you cut the epithelium at the medial and lateral lip. So that's just one technical point.
Rupert, just can I ask, sir, can I ask?
Yeah.
Anterior posterior band, is there any protocol of which do you prefer cutting first? I remember an interesting point came up in discussion once in Kerala.
So usually what happens is that it's, when you cut one band, the entire release develops. You don't have the tensile strength anymore. So it's typically easier to cut the anterior band and have the cyst retract posteriorly because you can see the posterior band very easily. So I prefer to do that, but there's no hard and fast rule. But the reason being, once you cut it, you've lost the tensile strength.
But it is a very valid point. The bands are important. You will see the ease in dissection if you just give 2 laser cuts on these bands. Any cyst, especially this mucus retention cyst, comes out very well.
And I must say, for the non-laser people, it's a real skill and interesting thing to use the sharp scissors in and around the system. It's the thing. This is the thing we're doing.
Now, this is for Dr. Annaga. Your observations and how will you tackle, Dr. Annaga?
Yeah, there's definitely a cyst on the left vocal fold, but I see a small sulcus on the opposite side, on the medial aspect of the right vocal fold. So while explaining the prognosis to the patient, I would definitely talk to him regarding the sulcus and the management of the sulcus at the same sitting as the excision of the cyst, and that the patient will require speech therapy and voice rest for a longer period than would be required for if just the cyst was operated.
There is a sulcus, but only difference is from the previous case, it's a shallow sulcus. It is not a very deep sulcus. So maybe Dr. Nupur?
Also, we need to keep in mind in this case, the shallow sulcus is exactly at the point of the cyst on the opposite side. So very likely it's a contact depression, which is a little different from sulcus. So I think in this case, it would be well worth leaving it alone actually. It will resolve on its own once the cyst is out.
Yes.
I think a subepithelial infiltration during surgery might give us a better idea to the depth of the lesion.
You can start on stroboscopy itself. Though you must always palpate, but it is quite evident. And this sort of a thing doesn't need any intervention. You even with your hand it over to the voice therapist and it should be all right. Now, Divya, sulcus, bilateral sulcus. Palpated on table, grade 1 sulcus, bilateral.
For sulcus, basically, it is the closure which is basically affected. So glottic closure and the vibratory pattern. So we can work on the glottic closure, phonatory gap, and they would have vocal fatigue. So work on that, the relaxation techniques on improving that. And also on the, they would definitely, we can work on the pitch, because if it's a male, usually they develop a slightly higher pitch. So we work on the reducing the fundamental frequency, and also on the quality of the voice by strengthening the vocal muscles and the muscle tension. In case if they have developed, most of them would develop muscle tension dysphonia along with sulcus. So these are the pattern in which we work.
Straw exercises for sulcus, you feel they are helpful?
Yes, definitely. Because of the extra effort that they put on the vocal muscles, straw exercises really has shown a lot of changes. Though initially the patients don't accept that exercise, they find it very funny to do those exercises. But after a couple of maybe 10-15 days, they themselves tell that the straw exercises are helping them, and they feel a lot of relief at the vocal effort has tremendously reduced with straw exercises.
Now, this case, Dr. Nupur, this is for you. Now, she's a very senior consultant, gastroenterologist. Bad voice, bilateral sulcus.
There seem to be some kind of swellings in bilateral striking zone also with an absent mucosal wave there. Yeah, if you can.
Yes, it is not a very pliable cord. It's the mucosal wave at least is reduced, if not absent. And it's
wouldn't really appreciate too much of a mucosal wave. If you could just see it one more time. So I would definitely like to take her under general anesthesia for examination to see whether there is some kind of a cystic lesion at the striking zone. And at the same time, I believe very strongly that for sulci to really understand their depth of penetration and length, one needs to take them under general anesthesia and palpate them and perform an infiltration. I like to kind of take an consent from these patients after having a detailed conversation with them, that depending in laryngology, very often we find things which we may not expect also. So I want to understand from them, do they want me to tackle them as per what I think is correct on table? And so if there's a sulcus which I feel is deep, I would like to do maybe a laser-assisted sulcus release. If at the same sitting there's also a cyst on palpation, I would want to excise that too. If there's a contact lesion, I may leave it well alone. So a lot of the combination elements finally get decided on table. I also want to mention over here that, when there are a lot of classifications mentioned for sulcus. So when we say like a grade 1, according to the Charles Ford, there is 1, 2, and 3. But there, according to Boucher's, there was just vocalis vergature. And all these classifications are based on stroboscopy, because after stroboscopy, we can't exactly define the length and the depth of the sulcus. So it's only on palpation that we are able to define the length and depth, and then take a decision as to what we would like to do for the patient.
Right.
I think Nupur, you have come with a wonderful classification for these sulci.
Yeah, the new one.
We have proposed a very
Yeah.
simple classification, which is specifically after palpation under the microscope, where it's very simple. It's A, B, C, D, E, F. A, B, and C are the sulci which are more than 50% the length of the membranous vocal fold. If it's going only into the SLP, it's A, going into the ligament B, going into the muscle C. Similarly, D, E, and F are the sulci which are less than 50% of the length of the membranous vocal fold. D is going into SLP, E going into ligament, and F into muscle. So if we, and this can only be done after general anesthesia, ML scopy, palpation, infiltration. So if we use this very specific classification and give our surgical results, then globally we would have a better consensus as to which surgery is working where.
Now the question is, once you've done a laser release, would you like to implant something into the space or just leave it like that? Just do a release and leave it.
So very interestingly, we started by doing the release only for superficial sulci. That is the grade in our classification A and D. And now we have progressed to B and E. And very surprisingly, we are finding even when we cut the ligament, because in B and E, it's going into the ligament. It's amazing that they're healing, touchwood, really well. So we are gathering all our data. We're not doing any implantation because you're doing so much release, you can't implant anything. It won't stay there, basically. So we are doing the release now.
How are the phonatory results of?
Fantastic. Fantastic. So that is a surprising thing. I would have imagined it would only work for superficial, where the epithelium has to grow like this. And in ligament, it wouldn't work well because, it would be a fibrosis. But I think, I am not sure exactly what the science exactly behind it is at a microscopic level or ultramicroscopic level, but surprisingly, even the deeper ones have a very good phonatory closure pattern. And I've got all my matter together. We are in the process of publishing it.
Very nice. Okay. Now, we've already taken the sulcus surgery, your technique, you understand. We'll leave this also. Now, last few questions. Now, how much results you promise after sulcus surgery, Dr. Annaga?
For sulcus, I give a very guarded prognosis. But as Dr. Nupur mentioned, the results with laser-assisted sulcus release are surprisingly very good. We get good post-operative voice with the patient. And not only with laser, it's like if we do a cold steel surgery also, we have got good results with that. To take an incision like a modified Pontes, take an incision and take vertical incisions, horizontal incisions across the sulcus, that also gives good results enough. But obviously, like for as against for a polyp or a cyst, we do give a guarded prognosis to the patient, and would advise that and would also say that it will take a little while for the patient to regain his voice to a respectable level, because there is a lot of period. I mean, it takes a lot of time for reepithelialization for the entire thing to heal.
So I think this is very clear. Don't give a promised moon when you are handling sulcus. In fact, I err on the side of promising less than what we can deliver also. But surprisingly, sometimes the results are very good. We do implantation also. We release the sulcus, but I will implant fat or inject fat, depending on how much of the incision has been given. But I'm very curious to know more on Nupur's technique of just releasing it and see long-term results. Because sulcus is one of the gray areas in laryngology. It is not something which is everybody has an answer to everything. And
Can I ask a question?
Yes.
Especially for Dr. Nupur and Dr. Annaga ma'am, when you are doing either with the cold steel method of the modified Pontes, like madam mentioned, and for Nupur madam, when you're doing the deeper sulcus, I understand there is no space to inject anything at that point, but post-operatively, do you do steroid injection, or would you recommend trying steroid injections post-operatively?
Yes, definitely, I give steroid injections post-operatively.
Actually,
I don't give steroid injections post-operatively.
Okay.
I don't think there's any role as such of steroid injections.
You're talking of IV steroids or intralesional steroids, Gauri? IV.
No, I'm talking about in the vocal fold to prevent scarring, prevent fibrosis, something like
Difficult
that.
for steroid to stay there since already you've done dissection.
You make so many cuts. Where are you injecting the steroid? Into the muscle. If you inject steroid in the muscle, you'll cause muscle atrophy. That would be a disservice.
No, later on, after a while, during follow-up, not during the surgery. I meant in post-op setting.
We've not done it.
Because you have to specifically again take the patient even if it's office procedure, and you have to wait for the healing.
During the post-operative follow-up, do you mean, Gauri?
Yes, ma'am. That's what I meant.
No.
Now, just see this lesion, Dr. Unni. Dr. Unni, you get a prescription from another center, has been advised surgery. What is your take on this? Dr. Unni, you are still there?
Yeah, I skipped 15 to the score, so sorry.
Okay.
Any history, sir? Vocal cord
History
granuloma?
is, there is a history of foreign body sensation in the throat. He's come up to you. He's been advised surgery in, which is the other place in Kerala. I will not say Trivandrum. Some other LAP.
Any questions? Okay.
So what will you do?
So, the described conservative measures would be voice rest and an adequate course of PPI. So, first I would check whether that has been given. And then, of course, I would show the lesion and say that this needs excision, but with a little bit of guarded prognosis about the slight chance of recurrence. So, voice rest, adequate voice rest, strict voice rest to prevent the contact happening. And then the challenge, of course, on table also would be the intubation because it sits right there. So, what you showed at the beginning for MLS case, I think would be very useful, especially in such cases. But yeah, this case overall would looks like land in the OR. Would need excision.
Dr. Gauri?
Yes, sir. Definitely, this would need surgery. But at the same time, during surgery, I would inject Botox and long-term PPIs for this patient because this is obviously arytenoid granuloma, and the trauma, preventing the trauma post-operatively would be an important point. Because many times when you do a complete excision of arytenoid granuloma, you end up going up to the perichondrium or of the arytenoid cartilage and it would lie bare. So you want to prevent the opposite arytenoid hitting against it. So I would give him Botox, give this patient Botox injections intraoperatively and long-term PPIs.
Dr. Nupur? Surgery or no surgery?
Definitely farewell grade for contact granulomas. And I think there was one on the right side also, but the abduction was a very limited thing I saw. So I would inject a botulinum toxin in both the thyroarytenoid muscles, warn the patient that he or she is going to have a very soft voice. There is no aspiration usually in these patients. We inject usually 5 mouse units, give PPI for a longish period of time, and don't start any voice therapy for the next 6 weeks because the Botox is going to do the job. I've had patients, many patients like this actually, and they do very well with almost zero recurrence once you give the botulinum toxin.
So no surgery?
Surgery.
And then
you will excise and give Botox injection. Okay.
Botox, right? That's what.
So it's a contact granuloma, large size contact granuloma. Yes, you will excise, but 2 or 3 precautions. Once you excise, there'll be exposed arytenoid process. So you need to address that also, because if you leave too much of mucosa, again, this will reform. Perfectly all right to give Botox. In fact, the main treatment is Botox only into the muscle. Again, not into the lesion, into the muscle. We will make it flaccid. And the conservative measures are equally important. Your PPIs, lifestyle modifications, and give the patient, there is still, despite doing everything, 10% chance of recurrence. This is a lesion which, like nasal polyps, there is a fair chance of recurrence. Anyone who will try without doing surgery, just give Botox and conservative initially, or in the first go, you'll go for surgery. Dr. Annaga?
I think as Dr. Nupur mentioned, grade 3, grade 4 granulomas,
right,
who are which are almost reaching to the midline or maybe crossing the midline, those would definitely require surgery. But the grade 1, grade 2, I would always manage with conservative management, because they do regress with conservative management.
Grade 1
don't require
definitely, there's
surgery.
no doubt. Grade 1 definitely regresses.
It is the size which will matter.
Yeah.
Now, one of the last questions. See, we have a big problem with the cord injection material. We use fat, we use Restylane, hydroxyapatite. Even Karen was mentioning she stopped using hydroxyapatite. But we don't have a perfect injection material. All these, the duration is very short. Anything which can come up as a, say, permanent perfect material, Dr. Nupur?
I think when I went in 2007 to Harvard, Dr. Zeitels was working on the perfect injection material. So very easily sort of dreamt of. I just am sticking with hyaluronic acid, and 6 months later do a thyroplasty or medialization as needed. Of course, there's a lot of scope for a perfect injection material, which you can inject in the SLP. And we have, studies from Japan, which they are telling us about various growth factors which can be injected for sulcus and scar. I don't have any clinical experience with that, and I can only hope for something.
Dr. Ishiki's work on epidermal growth factor. So that is about scars and sulci. So this is still eluding us. I think our focus, people who have reached somewhere in this field, I think should be this. This is one of the problem areas, and has not been addressed despite efforts to get something which is worthwhile. I prefer fat, sometimes do Restylane also, but again, there is a limitation on the time duration, repeat injections. Now, I think we will not discuss this because already it has come up in discussion. There are few audience questions which I will take up before we call our day, because these are people who have sat through, and we must answer them. Now there is a question from Dr. Naresh Panda. How about anterior commissure lesions? I think I'll take this on because this is about the early cancer larynx. See, anterior commissure, again, as I said in my talk, you must visualize the lesion fully. You must see the anterior part, and you should be able to give a margin of 1 or 2 millimeters. But if you have an anterior commissure lesion, safest thing is to do a CCT neck to see the cartilage involvement. If you have a cartilage involvement, it makes it T4, and there is no role of laser at all. Even if there is a doubtful involvement of the inner cortex, here MRI is better than CT. Again, it's always a trade-off between a CT and MRI, which one to do. Soft tissue delineation is better with CT, with MRI, but cartilage is said to be better with CT. But if you want to see the inner cortex, then you must get an MRI also. If it is involved, then don't touch anterior commissure lesion. However, if your cartilage is free, then you can, up till the cartilage, in fact, even the inner perichondrium, you can dissect. The phonatory results initially will not be as great, but it is worth it. So we can do anterior commissure involvement. We can dissect with laser. There is another question from Dr. Rakesh Srivastava from Lucknow. A very good question. Are you doing biopsy in all early glottic malignancies before TLN? Dr. Nupur?
No, for many of the cases, we do go by the frozen also. And our retrospective studies have shown that the chances of a false positive are virtually zero. Sometimes you may get a false negative report on frozen. So it's not always that we are going with a biopsy beforehand.
So my take on this is we prefer to get a biopsy because, see, after all, it is a cancer. And even if the sensitivity of frozen is 90%, if in 10% there is a mistake, it is not worth it. Secondly, I'm not talking of lesions of uncertain etiology like, say, dysplasias, mild, moderate, severe, or even carcinoma in situ, where excisional biopsy is fine. But if you have a suspicion, preferable to do biopsy first, with few exceptions, where logistic issues, cost issues, patient agrees, You tell him, I will excise the lesion. This is the limitation. With the frozen, there's a chance of this 10%, 5%, and you may need different treatment. But that's an exception rather than a rule. We have centers who do what Dupur is saying. They follow the frozen and go ahead with the resection. But there are others who will base their this thing on a biopsy, even if it's an office procedure. You can take a biopsy in office also. You can put a fiber optic scope and take a biopsy. So this can have people can have different opinions, but you must be able to convince the patient and be, since there is a cancer involved, you should be medico-legally and you should have a protection for yourself also. Now, there is a question from Dr. Karnesh Gupta from Amritsar. Can coblation be used instead of laser for resection? I think, again, he's talking of cancer larynx. See, problem with cobblator is, the heat effect is less, but it's a very wide contact surface. If you've seen the wand of the cobblator, on the cord, it's a very wide surface. With laser, it's a very fine cutting. It's a very precise cutting, even up till 100 microns. Now, cobblator, if at all, if I don't have a laser, I will prefer a cold instrument. Cobblator I will use in two situations: for papillomas and for doing a posterior cordotomy for abductor cord paralysis. Apart from that, I will not touch the vibrating structure of the cord with a cobblator. Dr. Nupur?
So coblation, the thinner wand, even as you mentioned, is not as fine as a laser at all. So we take care of hemangiomas. That's one situation where the coblation is pretty good. And we've had some cases of glottic and supraglottic hemangioma. But and like you mentioned, Kashima, absolutely fair to use a coblation if you want. But we otherwise definitely prefer the laser.
And strict no for malignancy. Again, the malignancy, laser, even if you're doing fine margins, 1 millimeter, 2 millimeter, it is possible with laser cutting. Cobblator cutting is very diffuse, so I will not recommend it all. Now, there is another question from Sri Mandir Kumar. Is it possible to identify cartilage involvement clinically without imaging? Dr. Kumar is from Mysore. No. If you have anterior commissure involvement, you must get imaging done. There is no way clinically you can know whether cartilage is involved or not, except for being suspicious when it reaches till the anterior commissure. It may just be a proliferating lesion, which is involving the anterior commissure, but not involving the cartilage. So still it is either T1 or at the most T2. It is not T4. So you must do imaging. Now, there is another question from Meena Kale. In vocal cord cyst on stroboscopy, is it apparent, absent, or complete absent of mucosal waves? Why these waves are absent? Dr. Anga, can you take this on? In vocal cord cyst, why are the waves absent? That's the question.
Yeah, basically, the vocal fold cyst is a lesion which is involving the superficial lamina propria, and it also increases the bulk of the vocal fold. It hampers the vibrations, it hampers the vibrations of the vocal folds, and that is how it affects the mucosal wave more than it would be affected with a vocal fold polyp.
So is it only a mass effect or it is something more than that? Dr. Nupur?
So basically in polyps, you've got an excess of superficial lamina propria, and that can work two ways. It can even improve your amplitude of the mucosal wave or not, depending on how the polyp causes the phonatory gap to develop. But what happens with the cyst is there's accumulation of material, which may be keratin in epidermoid or just gelatinous material in a mucus retention, but it is surrounded by a wall. So when it's like a grape sitting in the SLP, and something like a grape in the SLP is going to dramatically decrease the amplitude of your mucosal wave.
Thank you. Now there's another question again from Dr. Meena Kale. What is a hard and a soft nodule? Dr. Anaga, you can again take this. Difference between a hard and soft nodule?
Yeah, basically where a softer nodule will look more translucent and it is more amenable to speech therapy and voice rest and voice therapy. As the nodule progresses and becomes more chronic, there's thickening of the overlying epithelium, hyalinization which occurs, and thickening of the basement membrane zone, and it looks more fibrotic and whitish on appearance and more solid than translucent.
Now,
So that which is less amenable to voice therapy and speech therapy.
There's one more point would be the stroboscopic picture, the mucosal waves being definitely much worse on the hard nodules.
Now, this is a question from Patna, Dr. Navneet Mukul. How effective is Store's laryngofit instruments in phonosurgery as compared with the contemporary MLS instruments? Dr. Nupur? So laryngofit is something, I'll answer that. Laryngofit, it's a sort of a flexible instrumentation. I have seen it, I have in demonstration, but I don't think it matches the conventional instruments what we have. It is only to save, say, probably a bit of the cost, but my view, not as effective as your conventional instruments what we use. Then there is a repeat question which has already been answered by Dr. Kevin Kumar. This is about the Botox in lateral cricoarytenoid in arytenoid granuloma. It's already been answered that we do use. There are centers which use, and it's perfectly all right even after excision to inject with Botox. Coblator debrider, Dr. Munka is already answered. Debrider again, coblator we answered. Debrider again, the only indication is papilloma for initial debulking. It causes bleeding. You use a skimmer blade, but for huge papillomas where time is essence, you can debulk initially, but near the cord, switch over to the laser. That may be faster for large size papillomas. Otherwise, no. Now, this is a question about nodule, polyp, voice therapy, already answered from Dr. E.R. Vinay Kumar, Hyderabad. For Reinke edema, which steroid and for how long before surgical intervention? Dr. Nupur? You said you use steroids. Yes, yes. She doesn't use steroids. Who was using? Gauri was using steroids. Yes, Gauri.
No, sir, not me.
Anaga was using steroids.
Yes, Dr. Anaga.
Yeah, I would give a proper dose of steroids for Reinke's edema. Maybe for an adult, I would start with 40 milligram per day and then taper it over so as to decrease the edema and the congestion of the vocal cords.
Dr. Nupur, what is your rationale for not using steroids? You can reiterate again what you said.
Sure. I find that most of the patients do have a laryngopharyngeal reflux, which may be responsible for the grade 1 Reinke. So steroids may work even worsening this kind of a reflux situation. So I wouldn't want to. I would want to give them long terms, not only PPI, but even alginate in terms of Gaviscon, 15 ml after dinner, rather than steroids.
No, but anything you have against steroids? Is it the type of pathology in, say...
I personally don't believe that Reinke's grade 1 edema or grade 2 for that matter would resolve with steroids. So I, don't give it.
Fine. Now there's a question from Hyderabad, Dr. Anjanelu. Nowadays, use steroids carefully. If any fungal infection comes, possibly patients may raise voice against our treatment. Yeah, that's fine. Steroids in days of COVID and with black fungus, mucormycosis, I think that is a valid point. No overuse of steroids. And actually in voice, I think the only true indication for steroids is a vocal cord hemorrhage. Otherwise, indiscriminately, we should not use steroids. Most of the non-surgical patients can be treated with correct voice therapy, reversing the compensatory behavior, lifestyle modifications.
In fact, we have found that patients are often treated with steroids when they have a unilateral vocal fold congestion. And that may be a situation of tuberculosis, which is not secondary but primary. And we've seen one patient who was treated such, and it became a fulminant tuberculosis after that. So really use of steroids, I think, is something we should
Yes.
Curtailed when needed.
I think that should be a strong
Also-
message. You can have yes.
Also the use of antibiotics for so-called acute laryngitis. I think
time has come when this term laryngitis should be discarded.
Absolutely.
Because actual infection, the incidence is very low.
No
Problem is, you see something red in the larynx or a very cursory examination, you label it as laryngitis. But now with our diagnosis improving, with gadgetry improving, our skill levels improving, we should be giving a specific diagnosis. Unless it's acute laryngitis, I don't think the chronic laryngitis should be taken off ENT textbooks.
Completely. Totally.
Acute is acceptable. You can have acute laryngitis, but not chronic laryngitis. Now, I think the last question is, which steroid is injected into nodules? How much? Panelists said they don't like to inject steroids, but I have seen people do as office procedures. So DEXA can be injected. Dexamethasone is in the injectable form. If you're doing office procedure and for some reason you are doing, it should be DEXA, which should be injected. So with this, we call it a day. I thank all the panelists, Dr. Nupur, Dr. Anaga, Dr. Unni, Divya, and Dr. Gauri. You've taken their day off. Out of the 5 panelists, 4 are ladies, and today is our festival, we know. So thank you very much. It was a very, very interesting discussion, and all of us gained from each other.
Thank you.
Thank you so much for a very well-conducted panel discussion. Thank you so much. It was a great
All
discussion.
the best to everyone for the remaining match.
Thank you. Bye-bye.
Bye-bye.
Thank you very much, sir, for the
Thank you,
wonderful
sir.
discussion. I think it
Thank
was
you.
still a lot of questions were coming, and I think the last question was also just now posted. So many
There's only one
viewers
question in India
Thank you, sir. Thank you very much.
Thank you very much.
Thank you. Thank you, sir.
Bye-bye.